I would like to start the panel discussion by maybe 1 or 2 questions from me. Actually, my first question is directed for Professor Lassie. I would like to ask you about how the COVID, what kind of lessons have we learned from the COVID pandemic, and how can we leverage some hepatitis services to advance the elimination of viral hepatitis?
Okay, thank you very much, Manal. As you know, the public health approach for viral hepatitis is a relatively new concept in Africa. And having been part of the COVID response in Africa, there are so many things we can learn. And one of these things is the development of a costed strategic plan at both national and provincial level. And in some cases, dissemination of the plan to the district level of care really helps in decentralizing the response. Additionally, the decentralization and integration into the existing healthcare systems really is a plus. And that is again what we're seeing in COVID. I'm talking about laboratory integration of hepatitis with other programs like HIV, like TB. I'm talking about surveillance, even down to surveillance. There's so much cross-programmatic efficiency that can be obtained. Additionally, partnerships. We cannot but talk about the need for partnerships. And for viral hepatitis in Africa, we're looking at the Egypt initiative as well. We're looking at implementing partners like CHAI that have just spoken, and of course the need for catalytic funding. Community engagement in COVID is key, and we need the same in viral hepatitis. And the virtual platform that we have now really is going to be instrumental in many things we do, in capacity building, in service provision, etc. Thank you, and over to you.
Thank you very much for this response. And I would like to relay one of the attendees' questions to CHAI. They are thanking CHAI for highlighting the Rwanda experience, but they do have some rare subtypes and genotypes that do not respond to the SOFDAC. And they can respond to the SOFVEL and the GP. And they would like to know how they can access those medicines at a high price of $270 per treatment. And this brings me also to a couple of questions about the pricing. How can we bring those pricing to other countries? Because the pricing of Rwanda and Egypt are brilliant, but they're not in the rest of the countries in sub-Saharan Africa. So what's the role of CHAI in all this?
Thanks, Manal. Well, first of all, let me thank you for that question, and thank you for the opportunity to be part of this opening session for COLDA. Manal, let me address maybe this latter part of your question that you asked me first, because I think it will then shed some light on the question that has come through the audience as well. So, you know, obviously in my presentation, I talked about how remarkably pricing for DAAs has come down. But you're right, these declines are yet to be reflected in a number of the countries that we all work and live in. And so, you know, while there's no one size fits all approach, what we are seeing is that there are some key elements across countries who are able to achieve better pricing. And CHAI's HCV market report that was just published in May lays out some of this information in detail. But let me just touch on a few key points. Firstly, what we know is that government commitment with dedicated budgets to scale public HCV programs can go a long way in helping negotiate better pricing. We've seen this in Rwanda. You know, although Rwanda has relatively a smaller population, they have achieved some of the lowest pricing globally through strong political will and reliable budget allocations. We've also seen that countries that have a large number of suppliers registered can benefit from accessing lower price per patient courses. And so it's important, one, to ensure that there are more generic options available. for the various DAAs, and then 2, to ensure that we're accelerating registration or time-limited import approvals for WHO pre-qualified and ERP reviewed products. And this is because with more products, you can ensure supply security in countries and increase competition among suppliers for lower prices, and also have more successful tender processes. We've also seen that countries can benefit from lower pricing by planning for and streamlining procurement. Programs that have aggressively scaled up treatment volumes have usually benefited from significant pricing breaks. And for orders in the range of over 3,000 patient courses for SOF and DAC, countries like Egypt and Pakistan have been able to receive very competitive prices compared to orders in the lower range. So just generally, I think the market intel report that I referred to provides some benchmarks and global ceiling prices for drugs and diagnostics, and stakeholders can use this information to negotiate better pricing during procurement. So I definitely encourage, various stakeholders interested in pricing and, involved in procurement to refer to that report. In regards to the second question, I'm not familiar with the study that's being referred to. I'll have to go and look at it. But what we do know is that soft DAC is currently the most available regimen in lower middle income countries. It's the most affordable right now. And at least from some of the data that we're seeing across the countries we work in, it's effective, over 95% effective. But this doesn't mean that we shouldn't be continuing to work to ensure that other DAA options are available in countries. And some of those factors that I just talked about before can help with this.
Okay, thank you. And my next question would go to Professor Moubai about Senegal. Now you have a lower prevalence of hepatitis C, but the hepatitis C prevalence seems to be in the high-risk population groups, like the injecting drug users or the drug users and the multiply transfused. Can you please comment on what kind of plans do you have in Senegal for those high-risk groups that are driving the prevalence of hepatitis C?
Bon, il y a un bruit de fond très, très gênant. Je n'entends pas bien du tout. Quand je mets en traduction de français, quand je mets en français, il y a un bruit de fond extraordinaire. Je n'entends pas bien. Aussi bien les commentaires que tout ce qui est dit. Donc la question, je ne l'ai pas bien entendue parce qu'il y a un bruit de fond très, très important qui gêne quand on met la traduction en français. Est-ce qu'on peut reprendre calmement la question parce que je n'ai rien entendu, hein, M. Fall?
I think if we can send the question translated to Professor Moubai, and we'll move to the my next question to Kenneth until this question is received by Professor Moubai. Kenneth, I would like to ask you, what's the role of your organization? Of course, Dr. Kenneth is from the National Organization for People Living with Hepatitis B in Uganda, and we're happy that he's joining. I would like to know your role in improving access of women and children to the services of both testing and treatment for hepatitis.
Yes, thank you, Professor Manal. As an organization, we have been trying to raise awareness amongst the population and also the pregnant mothers, though it has been actually done on a smaller scale because of the lack of support in terms of funding to help us reach all the mothers in Uganda. But recently, we have also been advocating for the introduction of birth dose, which I am happy to report to you that at least the Ministry of Health under the expanded program on immunization has actually supported, and they have actually bought into the idea of introducing the birth dose, I think in the next few years to come. But the challenge also lies in the issues of access to testing. even when we have the will and also the policy in place that all pregnant mothers should be screened for hepatitis B, routinely it is not done because most of the time you find that these test kits are not availed at the antenatal clinics. So maybe if the mothers can actually request for these services in private health facilities, that's when they can be able to be tested for hepatitis B. But also, we know that the cost of testing is a bit high. So we are thinking that it can be targeted. For example, if the pregnant mothers test positive, then their children can be given the hepatitis birth dose, so that we leverage on that than giving all the mothers who test for hepatitis B and others who are not who do not actually who are not found positive with the disease. And this is something that the ministry is actually looking into because of the lack of resources to provide birth dose for all the children that are born to the pregnant mothers, irrespective of whether they are positive or negative for hepatitis B virus.
Thank you very much, Kenneth. I think I think we'll go back to Fumi again with a couple of questions about engagement of the Global Fund into supporting viral hepatitis, and another question concerning Cameroon. How can they engage their government to start an action plan for viral hepatitis and implementation?
Thank you very much, Madam Manal. Two quick ones. I think when I talked about public health approach, I think it's important to know that this is getting government buy-in and getting government to take the lead for converting viral hepatitis to a public health program. Example has been done in HIV and TB. In that kind of setting, there's a lot of benefit to some of the things Aurel talked about. When the government is taking the driver's seat, there's access to procurements and supplies that are cost effective and becomes very important, with multiple suppliers that will bring down the costs. And the examples in Nigeria is because of that, because the government is not a passive partner, but an active partner that also will create an enabling environment for viral hepatitis as a public health response. In terms of Cameroon, the strategic plan was launched on the 28th of last month with the Permanent Secretary of Health, plus many partners, including, I think, Chai and EGAP and various other partners. So Cameroon is well on its way to starting a hepatitis public health program. Additionally, with the support of WHO Afro and the regional office, we've done the preliminary hepatitis surveillance in Cameroon, and the burden is huge. I mentioned integration with pre-existing programs. So right now, Global Fund is beginning to agree to this concept of integration. And I know that now, within the HIV program, they are looking at providing hepatitis C support within the HIV program. That is what Global Fund is well known for. So there is talk on further integration of programs and further support, and this is work in progress. Thank you very much, Manal. Thank you, and over.
Thank you.
Professeur Manal, Professeur May, vous pouvez écrire la question pour que je puisse répondre?
Can I say it in English again? It's supposed to be translated for your kind self. It's about surveillance or surveillance in the high-risk populations with hepatitis C and access to treatment. Do you have a program in Senegal for those populations at risk?
est-ce qu'il y a au Sénégal un programme pour les populations à risque?
Oui.
Effectivement, il y a un programme au Sénégal, mais du fait de la très faible prévalence de cette infection, effectivement, il y a un programme qui s'occupe des hépatites C, mais au niveau des patients hémodialysés et des patients qui ont utilisation de drogue par voie intraveineuse. Mais ce programme n'est pas très important et ne couvre pas tous les patients. Et tous les patients hémodialysés et tous les utilisateurs de drogue par voie intraveineuse, le programme ne touche pas tous ces cas. Il y a un programme, mais c'est un programme à minima. Est-ce que vous m'avez entendu?
Thank you. So I think there is a question also for Oriel again from Ethiopia. They're wondering about the support of CHAI for Ethiopia for similar programs.
Thank you. You know, I will say that you know, if we could work everywhere and support every country, we would. I think it's a question, again, of resource mobilization, but a lot of the lessons learned from countries we support, like Rwanda and Nigeria, can be applied in countries like Ethiopia, and we're currently providing light touch support you know, to the national strategic planning process that's happening there, leveraging the lessons that we've learned and the support that we've provided and experiences we've had in other countries in that process. So, you know, I think it really comes back to a question about resource mobilization. And, you know, I think this is a sort of an open question with no straightforward answer, but you know, if I could share just maybe a few perspectives on resource mobilization, building off something that Dr. Leshy said, you know, I think the most important challenge and opportunity right now is for countries themselves to finance the hepatitis elimination effort. You know, within hepatitis C elimination, we know that it's now realistic and affordable with drastic price reductions, and we now have the ability to provide diagnostics and cure through integrated and other approaches like task shifting right down to the health center level. It's not only just cost effective, but there is a cost savings approach. And this is sort of the investment case that we really need to be making to our Ministry of Health counterparts and our government stakeholders for financing programs and starting viral hepatitis programs. Even providing the most basic palliative care for people who have advanced liver disease and cancer is going to be a lot more expensive than starting a step-by-step approach to actively find patients who are chronically infected early on in the disease and treating them. So we really need to be working with you know, our ministries of health and with our ministries of finance to ensure that elimination of viral hepatitis programs is part of the UHC agenda and can be financed through that. You know, I know this might seem impossible given how countries right now are tight on resources as they're redirecting resources to the COVID-19 pandemic. But beyond government health expenditure, there are other ways that countries are starting to mobilize resources for viral hepatitis programs through health insurance, for example. My understanding is that Rwanda is looking to advocate for HEP services inclusion under the National Community Health Insurance to increase access to services. You know, other ways are through public-private partnerships in a way to share the risks and costs of investments while enhancing the development of innovation through partnerships. So that's just a few examples building off, you know, what Dr. Leshy was saying in the question with Cameroon.
Right, thank you very much for all the panelists for joining and for the interesting discussions.